Hello, my name is Dr. Don Buford, and I want to thank everyone for taking the time to have a look at this video. This is a recording of a video that was initially presented as part of the Interventional Orthobiologics Foundation's webinar series. The moderator was Dr. Walter Sussman, and I was the presenter. The topic of this presentation is rotator cuff calcific tendinopathy, and I will also present a clinical case study showing an actual patient evaluation and procedure that was done a couple weeks ago. The handout for this presentation can be found at the QR code at the top left, and I'll give a web address for the handout as well. I can be located at texasorthobiologics.com. First, I'd like to talk about the sponsor of this webinar, the Interventional Orthobiologics Foundation. The Interventional Orthobiologics Foundation can be found on the internet at interventionalorthobiologics.org, and the mission statement is actually pretty basic. The goal of the nonprofit foundation is to be the leader in developing ethics, standards, and educational guidelines in the orthobiologic space. As part of this goal, they have developed a curriculum that has been vetted and is evidence-based and now has over 85 procedures that are taught as part of the formal curriculum. This is postgraduate level training. It includes ultrasound and fluoroscopic training, and over 1,000 physicians have been trained at IOF courses. Basic IOF annual membership levels include the following. MD, DO, and DPM can join at a rate of $400 a year. Physician assistants, chiropractors, naturopathic doctors, nurse practitioners, physical therapists, and athletic trainers can join at the rate of $300 a year. Orthobiologic fellows, or those fellows that are in orthopedic subspecialties, can join IOF for $100 a year. Students in medical school or other training type programs can join for free. Membership comes with a lot of benefits that are detailed on the website and includes significant discounts off of coursework and annual courses. Next year will be our 10th anniversary IOF Max Conference. It will be held February 28th and March 1st at the Talking Stick Resort in Scottsdale, Arizona. This will be a new venue for us, and we're really excited about it. The ink is still drying on the contract. Talking Stick is an amazing resort. It has a casino. It has a championship level golf course. It has 8 or 9 restaurant options on site. And we are really looking forward to bringing IOF Max to this amazing facility. Please join us and go to the website at interventionalorthobiologics.org for more information and to make reservations. So my full list of disclosures is up to date on our Academy website at aaos.org for those interested. I am the director of the Las Vegas Regenerative Medicine and MSK Ultrasound course. This is a course we've been running since 2008. We have it twice a year now. The website is orthosono.com. It's a 2.5-day course. It includes regenerative medicine. It includes diagnostic and procedural instruction in ultrasound-guided procedures. We have the latest, greatest augmented reality ultrasound-guided injection trainers, which allow us to teach injections on live patients without using spinal needles. So you have to come see that. This July course will be the first time we've implemented this into the curriculum, and it truly is the future of MSK ultrasound training. I can also be found on these other social media outlets, and I appreciate all the conversations I have. I learn from all of you when we exchange ideas. So again, this is the handout link. It can be found at buford.info/IOF cuff, and the QR code will take you to that same handout. So just a brief slide about what is calcific tendinitis for those of you that want to delve a little bit deeper into the biomechanics of it and the biology of it. And basically, we're talking about hydroxyapatite deposits within these tendon regions. It's most common in the shoulder and most common in the supraspinatus portion of the rotator cuff. It's important to note that it's often asymptomatic and resolves on its own, but sometimes it does create a lot of pain and dysfunction, and it can mimic other conditions in those situations. So we have to be aware of it. We have to know that this is a definite source of pain around the shoulder, and the rest of this webinar will be about some of the most recent treatment options. Who gets calcific tendinitis? It tends to be people between the ages of 30 and 50. It is twice as likely to occur in women. It can be bilateral 10% of the time. 63% of the time, it's isolated to the supraspinatus tendon. About 1 out of 5 times, it's in the supraspinatus and subscapularis tendons. And about 7% of the time, it's in the infraspinatus and subacromial space. Now, the most common site is about a 1/2 inch to 1 inch medial to the supraspinatus tendon insertion on the greater tuberosity. So these are just some little facts just to be aware of as we look at this diagnosis. Why do people get calcific tendonitis? This is often the first question that our patients will have when they come in the office for an evaluation. And the easy answer is simply we don't know. There's lots of theories as a result. There are theories that just the natural aging process of the tendon can lead to these calcific deposits happening, that excessive wear and tear changes on the tendon can lead to areas in the tendon where this hydroxyapatite deposition happens. There are theories about decreased vascularity and decreased oxygen tension in the cuff leading to this disease process. There are also theories about increased pressure on the cuff, for example, from a type 3 acromion leading to this disease process happening as well. So there's probably many different ways that patients can develop this diagnosis, and we just have to be aware of all these different potential pathways. There are multiple phases of calcific tendonitis. Clearly, the one that brings most people in to see us is the phase where it's painful. And that typically happens when the calcium deposits, these hydroxyapatite deposits, get into the subacromial space or get into the joint and create a tremendous inflammatory reaction. It's important to note that this often resolves on its own, but the clinical problem that we're faced with and that our patients are faced with is that the post-calcific phase can take a year or even a year and a half. And most patients would much rather try some intervention that can significantly shorten that time frame. Important to note that when patients come to see us with pain, the underlying reason most of the time is that this hydroxyapatite crystalline disease has gotten into the subacromial space. And if you look at the subacromial bursa during these acute inflammatory phases, it is very erythematous, it is clearly inflamed, and it's not hard to understand why this is a very painful process during that phase. The X-ray appearance is pretty straightforward. These deposits come in different densities, but on X-ray, we often see these discrete white lumps or hazy areas in the area where we would expect the supraspinatus tendon to be inserting. This is an example of a relatively large calcium deposit seen on a AP view. On ultrasound, we see something similar in that we see a defect in the tendon, although remembering that ultrasound is an imaging modality based on density changes, what we see is a hypoechoic area within the substance of the supraspinatus tendon most often. Because these deposits are different densities, we don't always have the same ultrasound appearance. It'll be based on the density of the deposit. If it's a relatively dense deposit, we may see the image on the right where we have a hyperechoic superior border, and then below that, we have shadowing and a very hypoechoic area. Notice that on the image on the right, we also lose the cortical margin here because the calcific deposit, which is looks like a golf ball here, is so dense that it basically blocks all ultrasound signal from transmitting below it. In this example on the left, it's an example of a calcium deposit that maybe is not quite as dense. We still see some imaging detail within the deposit itself. These are just more clinical examples of ultrasound imaging of calcific tendinopathy in the rotator cuff. This is another example of a more diffuse, less dense type of deposit. One of the tip-offs here that allows me to say that is we can still see the cortical margin, this hyperechoic line here. We can still see it, although we know that there's a calcific tendinopathy process happening superficial to it. So that would suggest that this deposit and these areas of deposits are not dense enough to reflect all of the ultrasound signal back. And so this is just a side-by-side comparison view of X-ray on the left, ultrasound on the right. And this would start to give you kind of a basis for an imaging library to know what you're looking at when you see this on ultrasound. So why do anything if it goes away on its own? You've already hinted at it, but the number one reason is it hurts. And the number two reason is that deposits greater than about 1.5 centimeters don't go away anytime soon. So we have to be prepared to give our patients proper informed consent that these larger deposits not only take a long time to go away, but if they are an inch or more in any dimension, they act very often like rotator cuff tears because it's a space-occupying lesion within the tendon. The treatment options vary from things like we see on this slide: magnesium supplementation, calcium restriction. There are some good German studies suggesting that shockwave therapy may be somewhat effective for pain relief. Most of us have used analgesics and anti-inflammatory medications. These are typically most useful during the acute flare-up episodes. Physical therapy can be helpful, but is really not going by itself, not going to make the calcific deposits go away. Corticosteroid injections are also done along with a needling or barbotage. And when we do that, our goal is to remove as much of the deposit as we can, to remove this kind of offending material. Quite often, these deposits are the consistency of toothpaste. They're not solid like little pebbles. They are relatively easy to remove with a barbotage type procedure. And so in that procedure, we can needle and aspirate the deposit with ultrasound guidance. We often use some normal saline to help facilitate the barbotage. So barbotage simply means the repeated needling and aspiration and the injection of a fluid, such as normal saline, just to, again, to facilitate removing these hydroxyapatite depositions. What are the advantages of doing this under ultrasound guidance? Well, number one, it's an in-office procedure. It can be done the same day as the diagnosis if there's clinical reason to do that. Using ultrasound, we can precisely locate the calcification. We can see the needle tip going into the deposit as we needle it. We can identify associated conditions around the shoulder and the soft tissues. There is no radiation. And most of the time, it's just one treatment. Sometimes it may be two treatments, but most of the time, we're able to help these patients with a single, well-done barbotage. What is the technique? We'll go through this in a little more detail over a couple slides. I always mark the skin and obviously sterilize the skin. I give the patient a fair amount of local anesthetic into the subacromial space because we know that we're about to release a very inflammatory irritant. So I will preface the procedure by injecting 20 cc's of a local anesthetic, usually with some epinephrine, into the subacromial space. And we'll let that sit there and start to take effect before we actually do the barbotage. In my experience, if these are bigger deposits greater than an inch in any diameter, whether medial, lateral, anterior to posterior, about 1 out of 4 may go on to require arthroscopic surgery despite a successful barbotage. And the reason for that is because the tendon may be so damaged that it really is functionally a rotator cuff tear even after removing the calcium deposit. So these patients need to be followed after the barbotage to make sure that they return to function. And if they don't, then we consider surgical intervention at that time. This is pretty well studied in the literature. Here's just some examples of published clinical outcomes. There's a 60 to 70% chance of significant or complete symptom improvement and return to activities. That was documented in a study by D.A. Silver back in 2002. A. Rima in the Journal of Radiology documented similar results. There was a large study published in the Swiss Radiology Society Annals. That was also published back in 2002. They looked at 176 patients. They used an 18-gauge spinal needle. Their calcific deposits were assessed as being greater than or equal to 1 centimeter. 82% of the time, they only had to aspirate one time. And the patients reported a SANE score, or a percentage improvement, of 80% within 1 week. So that's obviously a very big selling point on doing this procedure, because if we don't do anything, remember, it could be 12 months to 18 months before these deposits resorb and symptoms are better. So if we can help somebody within a week, and oftentimes within a few days, it seems to be a very, very valuable intervention to consider. Now, here's a case study. This is a patient that came into my office. Just have you raise straight up to the front as high as you can. This is the initial evaluation. You can see here, she's 56.
Nope, nope, nope. I want to see what you do without.
I want to see her
Okay,
actual
tell me it's
forward
endurable,
flexion.
so. That's about it, huh?
Yeah, that's it.
Okay, come on back down, take a break.
So we can see
And
she's
just while you're taking
effectively
break,
got a
do the
frozen
right-
shoulder
the
as
right
well.
arm's normal. Yeah, okay. This arm, when was the last time this left arm could do that?
Tuesday night, even Wednesday morning when I woke up,
Okay.
it was sore,
Yeah.
but I could move it. It was during the day on Wednesday that it got worse and worse and worse.
Okay, and this is just Friday. So to be clear, it's only been like 3 or 4 days. You've lost that much motion. It's that sore.
Yes.
Okay.
So clearly, patients can develop loss of motion and pain in a very, very rapid fashion. That's how inflammatory this disease process can be. And so once we make that diagnosis, there's a couple other diagnostic things that we do as well. We want to see if this is a passive restriction of motion, like a true adhesive capsulitis, or if her motion is restricted just because of this tremendous inflammatory process going on. These are her initial x-rays. The unaltered x-rays on the left. On the right, we measure the calcium deposit, and it measures 23 millimeters in the medial lateral direction. And notice that her deposit's a bit more lateral than average. It's a little bit over the insertion of the supraspinatus here. Here we're looking at the outlet view. We can see she has a type 3 acromion, so maybe that had some influence on her development of this disease. When we measure the deposit in this anterior to posterior dimension, it measures 16 millimeters. These are the ultrasound images. We'll start the one on the left. And what we'll see here is this calcific tendinopathy is occupying an area of the tendon right basically in the central part of the screen here. We'll go to this image on the right. And we can see calcium even occurring laterally over the lateral aspect of the greater tuberosity. So it really is relatively far lateral, and it involves intratendinous portion and looks to be an extratendinous portion as well. So now with that information, we're going to discuss the options. She opted for a same-day in-office barbotage. We had a conversation about adding platelet-rich plasma, trying to address the post-barbotage problem of how do we really maximize the rotator cuff healing and filling back in that defect that had been occupied by calcium just 5 minutes before the barbotage. And so we are starting to use PRP for that and trying to see if that impacts her clinical outcomes, especially with these larger deposits. She did want to go ahead and augment the barbotage with PRP injection at the end. So this is the procedure that we use. I use the lateral decubitus position. We put the local anesthetic in the subacromial space, and then we waited about 5 minutes. We get our best image of the deposit, whether it's on a long axis or short axis view of the tendon, however you see it the best. And then we use an 18 gauge spinal needle and do multiple needlings into the area of the defect. And then we use normal saline just to irrigate and then aspirate the calcific areas. Quite often we'll see the calcium start to accumulate in the syringe with normal saline. I should mention that it's not critical that we remove all of the deposit. So if we get an x-ray post-procedure, if there's still a little bit of calcium on the x-ray, that's okay. We don't go back and do the procedure more. So just know that the goal is not removing all the calcium, it's to remove a significant portion of it. Sometimes the calcium is a little bit denser and it's harder to get a lot of it out, but as long as we do the barbotage and irrigate with normal saline, then we can usually count on the success of the procedure. The video on the left is just showing us putting that lidocaine into the subacromial space. So this is a long axis view, laterals on the right, medials on the left. We're just blowing up the subacromial space with lidocaine. Now, by waiting 5 minutes, most of that's actually resorbed by the time we start the barbotage. We don't still see all this fluid 5 minutes later. It resorbs that quickly into the soft tissues. Remember, the subacromial space is not an enclosed space, but it does give the patient significant anesthetic, and in my opinion, is clearly the right thing to do to get the patients through this procedure in the office. So after doing the lidocaine injection, we now are ready to do the barbotage. Here you can see the 18 gauge needle coming in. This is a calcific deposit here. We're going to needle that multiple times, and then we're going to also needle the distal insertion of the supraspinatus tendon. So as we needle that, remember, we're also injecting and aspirating with normal saline to effectively remove as much of the calcium as we can. by doing the lidocaine injection before doing this, we have a lot of time to get this done. The patient's actually quite comfortable. So after doing the barbotage and being comfortable with the amount of calcium we received, we then go ahead and do the PRP injection intratendinous. Now, we can't put 6 cc's or even 8 cc's of PRP into the supraspinatus tendon. So we place whatever the tendon will hold, usually 1 or 2 cc's. The rest of it I'm going to place into the joint for this patient because remember, she had some limited motion. So doing a dilatation with a lot of the plasma that we generated in the PRP process, to me was a good clinical idea. Hopefully would give her more motion and hopefully serve as an anti-inflammatory agent within the joint as well. The balance of the PRP, we injected into the subacromial space. So to put real numbers on it, we drew 60 cc's of blood, whereas we would normally make 6 cc's of PRP. We actually kept a little bit more of the plasma. We actually injected about, I think it was 10 to 12, call it 12 cc's into intratendinous, some of it into the joint, and some of it into the subacromial space. So there were actually 3 locations of injection based on her clinical diagnosis and what I thought would help her the most. So this middle video shows a posterior approach to doing a glenohumeral joint injection. You can just see the needle coming down here. And remember, this is an injection that's PRP. Now, as we inject, you'll see the joint start to expand. You'll see the hypoechoic region start to expand. You can even start to see the infraspinatus and posterior capsule start to lift off the joint as we inflate the joint with PRP. In this video on the right, we finished the injection, and now as we rotate the shoulder, you can see that we've clearly put a lot of fluid into the joint there. And again, we've put some into the tendon and some into the subacromial space. So that's our typical injection protocol for this exact clinical condition. Like always, you have to be the doctor and personalize your decision-making with the patient.
All right, Dr. Buford, this is the day of the procedure. Just raise straight up to the front.
So this is before the procedure. She came in actually the next day after her initial evaluation and wanted us to get it done right away.
Not a whole lot. Come on back down. Come out to the side, as much as you can, palm up.
So you can see she's limited. And now, right after that barbotage that I just showed, this is where she's at.
So we're going to check your motion. Keep going. Better, huh? Keep going. Any fire?
And so I think this is a lot better. She's not in as much pain.
You just looked at the x-ray that showed the most of that calcium that was there.
And then if you look at the x-ray on the right compared to the one on the left, you can see that calcium is mostly gone right here. There's still maybe a little bit of a wisp of calcium laterally, but we've gotten down, I would say, at least 90% of the calcium. And obviously we've still got some work on her range of motion, but she'll get that back hopefully over the next 4 to 6 weeks. So everyone's happy with that procedure. She's happy, I'm happy, and I think we've really done her some good today. So let's talk about PRP a little bit. When we talk about platelet dose, it's important to have the formula kind of firmly entrenched in your mind and have it memorized. Platelet dose is simply volume of PRP injected times the platelet concentration in the PRP. And when we look at a dose response curve for soft tissues, it seems that 3.5 billion platelets in a single injection is a cutoff. If we can get our platelet dose to 5 billion or higher, we have a much, much better chance of having a successful outcome. And this is not just for rotator cuff tendinopathy and not just for calcific rotator cuff tendinopathy. This is for all soft tissue. And the reason I say that is because we've studied that and published on it. And if you look at the left side of this linear plot, 14 out of 14 studies that documented PRP doses below 3.5 billion platelets did not show any statistically significant improvement in outcomes. And again, this wasn't just rotator cuff. This was all soft tissue, various soft tissue things, Achilles tendinopathy, patellar tendon, tendinopathy around the elbow, etc. If you look on the right side of that 3.5 billion mark, 9 out of 11 studies that had over 3.5 billion platelets in a single injection had statistically significant positive outcomes. And so that is why I say we should all be getting our doses above 3.5 billion platelets for soft tissue indications, based on the best current peer-reviewed pooled evidence that we have on the planet. Now, 3.5 billion is the cutoff. What if you go higher? The evidence certainly suggests that going higher is a good thing to do on PRP dosing for soft tissues. Just as a quick example that's relevant to this topic, this paper was published in 2021, and it looked at PRP injections for rotator cuff tendinopathy. All of the patients that were entered into this study had failed other injections and other conservative measures. They documented a PRP dose of 5 billion platelets, well above the 3.5 billion mark that we just talked about. And what they found was that in these patients that had failed virtually every other intervention, 94% showed an improvement in their pain scores and their functional outcome scores by 6 months. And maybe more importantly for the patients, 84% returned to sports at the same level by 3 months, and only 7% required a second injection. So that to me indicates that even going higher than the 3.5 billion threshold can get our patients even a better clinical outcome. We haven't really had a study yet clinically that shows that we can be too high in our dosing. So if I'm going to make a change in the protocol, it tends to be I'm going to go higher on the dose, not lower. The question we often get at webinars and seminars and at IOF Max or at our course is, how do I know I have 5 billion platelets if I don't have a hematology machine? And the answer is, well, you have to make some assumptions, and we have to run the math, and this is how we do it. If we all assume that our patient sitting in front of us has the lowest normal human platelet count of 150, then that means we essentially have to draw 60 cc's of blood. Typically, that ends up being 54 to 60 cc's, depending on how much anticoagulant you use. But the bottom line is we need to be pulling out a 60 cc syringe and filling that with blood and anticoagulant. That means our starting platelet dose, assuming, again, the low normal platelet count initially, our starting platelet dose is 8 to 9 billion platelets. So we're starting well above that 3.5 billion threshold. Now, step number 4 is we have to know our kit's platelet recovery percentage. And the question is, well, how do I know that? Well, Jerry Magalon and others have published on platelet recovery percentages for virtually all of the commercially available PRP kits that are on the market now. If you don't know, ask your rep or look at the white papers, or better yet, look at an unbiased source that's tested them all. We've done a lot of that testing. And like I said, Jerry Magalon out of France has several beautiful papers now with spreadsheets showing platelet recovery percentages. So if you find your kit's name on that sheet and its platelet recovery percentage is 60% or more, then you're good. And you know that you're almost certainly going to be above a 5 billion platelet dose for your patient if you draw 60 cc's of blood. However, if you look at this spreadsheet and you find your kit and the platelet recovery percentage hovers around 30% or 40% or even 50%, you might not be getting to that 3.5 billion dose even with a 60 cc blood draw. So you only have a couple choices in that situation, right? You can draw more blood or you can get a better kit. So I think it's really important, if we're going to put patients through this procedure, if we're going to charge them for these procedures, that we give them the best procedure that we can based on the literature. So draw 60 cc's of blood, use a good kit. And if you want to quantify your PRP and you don't have the ability to do it in-house, there are services available. This printout on the right is from Plymouth Medical and Joanne Tremblay. You can go online and punch in the numbers if you have a hematology machine, and it will nicely calculate this for you. You can see your platelet recovery percentage. You can see your platelet dose. I know there's other calculators available, and I would just urge you to use something on some frequency to make sure that you're delivering what you think you are. So thank you very much. Again, there's the QR code for the handout and the link for the handout. And hope to see all of you online, and hope to see all of you at IOF Max next February. And those of you that want a little more in-depth education on MSK ultrasound and regenerative medicine, you're welcome to come to the course, and that'll be found at orthosono.com. Thank you. All right, you can vacuum.